I start my talk. Dr. Bansi Sabu has given us a task because we are celebrating 75th year of the International Diabetes Federation. So I want to actually give a proud feeling to all of you and me myself that as far as history of diabetes is concerned, we are so proud of our Indian history that Charak Samhita, Shushruta Samhita and Braj Samhita, actually they did not even, they not only know the what was the diabetes at that time, but what was the treatment and management of diabetes at that time. And they knew everything in the Shushruta Samhita, and everything is written about the diabetes management. Unfortunately, we have forgotten, and the modern science, Egypt and China and all other countries have taken over the modern science, and later on US and Europe. So we are so proud of our Indian history. Then the history, modern history, the most controversial Nobel Prize was given to the insulin discovery, and probably you know or not, the Nobel Prize was given only to the Professor MacLeod and the Banting, Professor Banting. But the original works were done by Professor Banting and his student, the physiology student, the Charles Best. But unfortunately, only 2 persons were given the insulin, and within 2 months of the vacation, when the Professor MacLeod was not even in the Canada, and he has gone to UK for the vacation, and these two people, Charles Best and the Professor Banting, he was the orthopedic surgeon, and they actually discovered the insulin, and you know all the history of that thing. Later on, when the Nobel Prize was given, Banting did not go to take the Nobel Prize, only Professor MacLeod went to take the Nobel Prize, and this was the whole history. The Professor MacLeod shared his Nobel Prize with the Professor Collip, who was the biochemist who later purified the insulin, and was given to the Leonard Thompson, the 14-year boy, came from UK. And the Professor Banting actually shared his Nobel Prize, the prize money with Charles Best. So this is the most controversial Nobel Prize to be given. And let us now talk about the beta blockers. And again, I am giving one of the history of that. Probably you know or not, Professor James Black was the only scientist in the world who got the 2 Nobel Prizes for discovery of beta blockers. First, which was the Endiral, was the blockbuster at that time. Professor Menoria, you know, must be knowing. Professor James Black, he discovered the beta blockers, and later on he discovered the H1 receptor blocker, and the drug was the cimetidine. Again, with these 2 drugs were the blockbuster at that time, #1 selling drug in the world. So let us talk about the beta blockers, and really this drug is so useful, you will realize within next 10 minutes or so. So these are my disclosures, and dear friends, my clinical context here is that we have to learn about all these things, that around 70 to 80% of type 2 diabetes patients have hypertension, do all agree with me. But if you have a hypertension and diabetes, then you have 3 to 4-fold increase of the cardiovascular disease. And in fact, what the beta blocker does, they improve the outcomes of post-myocardial infarction. They're very, very important drugs in heart failure, especially the reduced ejection fraction heart failure. But the concern of using beta blockers in diabetes was the worsening of glycemic control at that time, it was thought, and some of the masking of hyperglycemia or hypoglycemia unawareness. So important thing is that there is always a clinical challenge of balancing the cardiovascular protection versus metabolic derangement. So we have to actually see how the beta blocker does, but we need a very agent specific choices, and now we have the cardioselective beta blockers. Before I go for the real beta blockers, we all know that diabetes and cardiovascular disease are interlinked, and if you see here, it is the insulin resistance, glucose intolerance, blood pressure, inflammation, dyslipidemia, endothelial dysfunction, and they actually have the outcomes of having the cardiovascular disease, the coronary artery disease, heart failure, arrhythmia, and of course the sudden cardiac death. So what are the historical concerns? First is the masking of hypoglycemia, peripheral vasoconstriction, and insulin resistance. These are the three things we have to see when we are using the beta blockers. So how the therapy works? The potential therapeutic options, actually we all know that for all the cardiovascular disease, it is the ACE inhibitors or ARBs, beta blockers, and calcium channel blockers. And what the 2023 systemic review says that beta blockers application may improve all cause mortality and cardiovascular death in coronary artery disease in the case of diabetes mellitus. So how the pharmacotherapy of hypertension, probably we know all these things, but this is very, very important, how the drugs all the drugs are being used. The most important is here is the vascular tension, cardiac contractile force, and the sodium. These are the three culprits. Actually, they lead to peripheral vascular resistance, circulatory fluid volume increases, and lead to hypertension. So there are few drugs like angiotensin converting enzymes inhibitors, ARBs and ACE inhibitors, and they actually decreases the RAS activity, and through that reduces the tension and control the hypertension. Another thing is around the calcium channel blockers, which directly reduces the vascular tension, reduces the vascular resistance, and improves the hypertension. Then the alpha blockers and beta blockers again increases sympathetic nervous system activity, which is very, very crucial for the hypertension causes. Then it blocks the increased sympathetic nervous system activity, decreases the cardiac contractile force, and through the vascular tension improves the hypertension. And then the diuretics actually reduces the amount of sodium, reduces the circulatory fluid volume, and ultimately controls the hypertension. So these are the few drugs which we use very commonly in hypertension. So how the beta blockers, the basics of beta blockers are, there are beta 1 selective beta blockers like metoprolol and bisoprolol. There are non-selective beta blockers which blocks both beta 1 and beta 2 like propranolol. Vasodilatory beta blockers like carvedilol, nobivolol. So what is the mechanism of concern when we are using the beta blockers? Reduces the insulin sensitivity via beta 2 blockade, reduces the muscle perfusion, reduces the impaired hepatic glucogenolysis is suppressed, and because of that the hypoglycemia is masked. And of course the cardioselectivity matters a lot when we are using the beta blockers. So there are several selected indications like chronic coronary syndrome, post-myocardial, very, very important drugs. Acute coronary syndrome and heart failure, both reduce ejection fraction and preserve ejection fraction heart failure. Atrial fibrillation and hypertensive disorders in pregnancy, of course. Then the other favorable indications are there, but of course we have to give the drugs with caution. So how the beta blockers actually they work across the cardiovascular continuum, rise from if the patient have the risk factors like hyperlipidemia, hypertension, diabetes, smokers, then left ventricular hypertrophy, atherosclerosis, coronary artery disease, myocardial ischemia, every continuum of the cardiovascular disease including coronary thrombosis, myocardial infarction, or even reduces the sudden death. So this is very, very important, and of course reducing the remodeling, ventricular enlargement, heart failure, and ultimately reduces the death. So all the cardiovascular continuum, this drug is being used, and of course there are hypertension, and 2023 ESH guidelines clearly said that initiation of 2 drug combination therapy in recommended for most hypertension. This is 1A evidence. Heart failure, basically they are very used, and they are cornerstone treatment for the heart failure. And of course, coronary artery disease by Abyss study and reduced MI study clearly suggested beta blockers in coronary artery disease. We all know that there are different types of cardioselective beta blockers. Some drugs with increasing sympathomimetic activity known as ISA, and some drugs do not have the increasing sympathomimetic activities, and these are the drugs like, if no ISA is there, like propranolol, but with ISA is like pindolol and the acebutolol and other drugs and labetalol. So beta blocker selectivity is very important. Of course, if there are different beta blocker selectivity, all the beta blockers are different. Bisoprolol has probably the highest beta 1 selectivity, and again the pharmacokinetic variability is very important for all the beta blockers. And if you see here, pharmacokinetics of different beta blockers, and of course whether it's the plasma elimination half-life, absorption, first pass, bioavailability and protein binding, bisoprolol tops, then atenolol, metoprolol, all are good, but little bit matters pharmacokinetics. So there is a first important thing is risk of new onset of diabetes, and of course there is meta-analysis which showed that beta blocker increases the new onset diabetes by 22%, but later on several studies were done and it was shown that the risk was highest with non-selective beta blockers than the cardiovascular selective. So actually I'll go in a little later. The ADA standard of care clearly said that of course the beta blockers are not the first line of drugs for management of hypertension and diabetes, but you have to use in case of heart failure, post myocardial infarction and certain arrhythmias. So beta blockers in hypertension is very important, and we know that hypertension is very unique in diabetes. Like most of the diabetes patients have isolated systolic hypertension. They have less reduction in nocturnal blood pressure. This is again very important. High baseline heart rate is there, and most of the time they are resistant to most of the drugs. That's why we have to use 2, 3 or 4 drugs in diabetic hypertensives. So sympathetic activity is very important. I'll not go into the detail because time is shortage, but it is the beta 1 adrenergic stimulation is very important for causing the hypertension. And if you see here, the patient with hypertension and diabetes has the highest sympathetic activities. Hence the beta blockers can be preferred antihypertensive agents in most of the time. Of course, you have to combine. Can I take 1 minute more? Yeah, because it was 13 minutes only and I prepared for 15 anyways. So the drugs, the beta blockers in combination with ARB is one of the best combination for management of hypertension and diabetes. Similarly, if the patient is having coronary artery disease, I think the important thing is that if you compare the non-diabetics versus the diabetic coronary artery disease, it is the all-cause mortality. If you see that beta blocker can be used in reduce all-cause mortality if you use in the post-myocardial infarction or coronary artery disease. So that's why AHA and ACC clearly mentioned that with CAD and with heart failure, beta blockers are very essential, especially in the reduced ejection fraction heart failure, post-myocardial infarction and stable angina. And similarly, in NICE UK hypertension guidelines last year recommended clearly that of course it is not the first line, but you have to use in combination with other drugs like ACE inhibitors or ARBs. So dear friends, there are several benefits of beta blockers in heart failure and diabetes. And this is the last one. It is the practical actually tips. The first important tip is that you have to counsel the patient when you are prescribing beta blockers. What counseling should be done? It can mask the tachycardia or hunger that signal the hypoglycemia. So you have to counsel the patient. You have to ask the patient to regularly monitoring their blood sugar through SMBG and keeping the precautionary snacks always with them. Of course, this is very important thing. Nowadays, cardioselective beta blockers do not have that type of things. And of course, you have to monitor lipids, glucose, HbA1c periodically, very, very important thing. And of course, this is the most important, the last one is that sometimes the patient should not stop the drug, beta blockers especially, that rebound hypertension can occur and that will be very, very dangerous. So please do not ask the patient to not to abruptly discontinue the beta blockers and that thing. So please, dear friends, use the beta blockers wisely, very, very good drugs with the combination, and the cardioselective drugs are very, very important along with ARBs and AS inhibitors.
Thank you,
so
sir.
Thank you very much.